Managing the difficult gallbladder, a structured approach for surgeons. Welcome, listeners, to this deep dive into one of the essential challenges in general surgery, the management of the so-called difficult gallbladder. This term refers to those cases where factors such as severe inflammation, unusual anatomy, or patient health issues make the standard minimally invasive gallbladder removal highly risky and technically demanding. At the heart of this discussion is the principle of safe dissection and, above all, the prevention of injury to the bile duct. Today, we will walk through a comprehensive strategy that begins with careful preparation before surgery, continues with a range of intraoperative techniques, and emphasizes a readiness to alter course for the safety of the patient. Let us begin with the foundation, preoperative planning. Surgeons must be vigilant in recognizing the warning signs that might point to a particularly challenging gallbladder. Risk factors include characteristics such as advanced age, obesity, male patients, and anyone with a history of upper abdominal surgery. Clinically, the duration of symptoms matters. A patient who has been suffering for more than 3 or 4 days, or one who has experienced repeated episodes of gallbladder inflammation, is at greater risk. Radiological imaging contributes greatly here as well. Findings like a thickened gallbladder wall, persistent fluid around the gallbladder, a contracted or shrunken gallbladder, stones lodged at the neck, the presence of Merizi syndrome, or underlying liver disease all signal the need for heightened caution. Reviewing all available imaging is crucial, and sometimes additional studies are warranted to clarify the anatomy before proceeding. Once in the operating room, the guiding principle is the achievement of what surgeons call the critical view of safety. This systematic approach to dissection is designed to minimize the possibility of misidentifying structures and injuring the bile duct. It consists of 3 steps. First, clearing all fat and fibrous tissue from the triangle bounded by the liver, the duct from the gallbladder, and the common hepatic duct. Second, confirming that only 2 structures connect to the gallbladder, the duct and the artery. And third, partly separating the gallbladder from the liver to reveal the underlying plate. If, at any point, these steps cannot be safely completed, the situation calls for alternative strategies. The experienced surgeon draws from a repertoire of approaches when the surgery becomes difficult. One such technique is the fundus first or dome-down dissection. Here, instead of beginning near the vital structures, the surgeon starts at the far end of the gallbladder and works back toward the area of greatest difficulty, allowing for identification of structures from a safer vantage point. Another strategy is the subtotal, or partial, cholecystectomy, a definitive solution when the anatomy is too obscured by inflammation or fibrosis to safely continue. In this approach, as much of the gallbladder is removed as feasible, leaving part attached to avoid injury to surrounding structures, and the main goal is to clear all stones while minimizing the risk of complications. Surgeons have additional tools at their disposal. Intraoperative cholangiography, a method for mapping the bile ducts during the operation, can clarify unclear anatomy or confirm suspicions about the identity of specific structures, thus preventing inadvertent injury. Gentle, blunt dissection techniques, using specialized instruments to push tissues apart rather than pulling, help expose planes without tearing fragile structures. Modern energy devices also play a role here, helping control bleeding in inflamed and delicate tissues more effectively than traditional methods. There are moments when the safest decision is to convert to an open surgical approach. This is not a failure of technique or judgment, but rather a reflection of the surgeon's commitment to the patient's well-being. Indications for conversion include lack of progress, uncontrollable bleeding, suspicion of injury to the bile duct or bowel, inability to clarify anatomy, or the discovery of unexpected conditions such as cancer or Merizi syndrome. The open approach provides better exposure, more tactile feedback, and greater ability to manage major bleeding. Not every patient is a candidate for immediate surgery. When a patient is critically ill or unstable, a percutaneous tube can be placed to drain the infected gallbladder, buying time to control the infection and inflammation before pursuing definitive surgery later. In certain complex conditions, such as Merizi syndrome, a combined approach with endoscopic stenting before surgery can make the eventual operation safer. For rare or highly complex cases, referral to a specialist in liver and biliary surgery is recommended. After a challenging gallbladder removal, careful postoperative management is crucial. Drains are often placed to monitor for potential leaks, and there must be a high index of suspicion for complications such as bile leaks, retained stones, bleeding, or infection. Additional imaging and therapeutic interventions are used as needed. To summarize, the successful management of the difficult gallbladder is rooted in anticipation and recognition of risk, a disciplined approach in the operating room, a readiness to change tactics, and unwavering prioritization of patient safety. Achieve the critical view of safety. Have a defined bailout strategy. Use imaging tools liberally. Convert to open surgery when warranted, and never hesitate to ask for expert help when the situation calls for it. In the end, technical skill, sound surgical judgment, and humility are the surgeon's best allies in ensuring the best outcomes. Thank you for joining this in-depth discussion. Until next time, stay curious and stay safe in the operating room. If you enjoy the content, please like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.